And now I'd like to introduce today's speaker, Dr. Richard Grant. Dr. Grant is a primary care physician and research scientist at the Kaiser Permanente Northern California Division of Research. He is also professor of health system science at the K.P. Bernard J. Tyson School of Medicine and adjunct professor in epidemiology and biostatistics at UCSF. His research focuses on care delivery innovations for older patients with complex medical and social needs. Dr. Grant also serves as director of the KP Delivery Science Postdoctoral Research Fellowship and regional director of research and evaluation for complex needs for KP Northern California. He previously chaired the American Diabetes Association's Professional Practice Committee and recently completed a 3-year tenure as associate editor at JAMA Internal Medicine. And now it's my pleasure to turn it over to Dr. Grant.
Thank you, Raha. That was a long list of stuff. I'm kind of embarrassed now. Thanks, everyone, and thanks, Mike and Cynthia, for inviting me to come talk about a recent research study that we completed and published. So I'm going to be talking today about our study, which is reducing treatment risk in older adults with diabetes mellitus, and we'll call it the RetroDM study. And listed under my name are the names of all my co-authors and co-investigators. Hang on. Okay, I have no conflicts to disclose, and I am totally stoked to be invited to the US Deprescribing Research Network. I looked on your website, and your motto or credo or something, deprescribing refers to the thoughtful and systematic process of identifying problematic medications and either reducing the dose or stopping these medications in a manner that's safe, effective, and helps people maximize their wellness and goals for care. I imagine that at your chapter meetings, you begin with a recitation of this. What's interesting from a research perspective is that deprescribing is not easy. And what we need to get better at and understand how to do is how to engage patients and clinicians and the health system in this process in a seamless and patient-centered manner. So like all good research projects, we have to start with alarming people about how terrible the problem is. So about 10, 15 years ago, a lot of data started coming out about the problem of hypoglycemia in older patients with type 2 diabetes. This was a seminal paper that demonstrated that hospitalizations for hypoglycemia started to outnumber hospitalizations for hyperglycemia. And this is a natural consequence of us getting our act together and doing a much better job of managing type 2 diabetes with the goal of lowering A1Cs and controlling blood sugars. The problem is we might have gone a little bit too far, particularly in older patients, because now we have a fair amount of hospitalization for hypoglycemia. And why does this matter? Well, hypoglycemia hospitalizations are associated with dramatically greater 4-year mortality, 60% versus 19% over 4 years, compared to similar patients who were not hospitalized for hypoglycemia. It's associated with significantly greater risk of fall-related fractures. And you all know the story of the older patient who falls and breaks their hip, goes to the hospital, goes to their nursing home, and never gets out again. So this is a major issue. Also, hypoglycemia has been associated with poor cognitive ability, accelerated cognitive decline, and self-reported hypoglycemia is associated with increased burden of depression. So clearly, I'm preaching to the choir here, but clearly this is an important problem, and we would need to address this problem. And the most obvious way is to be more careful with the medications that we prescribe that lower glucose levels. So going to more recent research, what are the barriers and facilitators to deprescribing in type 2 diabetes? So there's a recent national survey of physicians conducted by Dr. Pila and group, and found that while the US physicians think de-intensifying is a good idea, there's some ambivalence about relative benefits and harms, and also concern about how this could potentially be a source of conflict with their patients. On the patient side, there's a recent in-depth qualitative study interviewing older adults about diabetes deprescribing. And the things that facilitated deprescribing were understanding why, the prescriber rationale, having a sense that the prescriber knew what they were doing, and that by reducing medications, there would be a benefit to that. So in this context, we can summarize by saying that the risk of medication-induced hypoglycemia increases with age. The consequences of hypoglycemia are severe. Deprescribing can involve complex decision-making and relies on effective patient and provider communication. And to be effective, this communication requires informed collaboration. So with this background of evidence and research publications, we implemented the retro study, reducing treatment risk in older adults. So our guiding question was, how can we encourage PCPs, primary care physicians, and their higher risk patients to discuss diabetes medication deprescribing? So for this study, we focused on patients who were 75 years and older, had type 2 diabetes, and were prescribed insulin and or sulfonylureas, the two major categories of medicines that can cause hypoglycemia. We also focused on patients who had an A1C less than 8%. Less than 8% is considered relatively good control. So we have very old or older patients on risky medicines with relatively good control. This study was funded by the Patient-Centered Outcomes Research Institute, so big thanks to PCORI. And as part of the funding mechanism, we were required to do a comparative effectiveness randomized clinical trial. So comparative effectiveness, as the name implies, means that you randomize two different active arms. The two arms that we randomized were academic detailing, which I'll talk about, compared to academic detailing plus a patient pre-visit handout. Our primary outcome was deprescribing within the 6 months following the index visit, which is the visit after the physician had academic detailing, and when the patient had either the handout that I'll describe or a kind of a placebo handout. And so we gave 6 months for changes to be made. And we defined deprescribing in our study as a reduction in dose or discontinuation of diabetes medications, switching between high risk or lower risk medications, for example, long-acting sulfonylurea to a shorter acting one, or reducing the total number of therapeutic classes. In addition to our primary outcome, we also conducted patient surveys looking at self-reported hypoglycemia, diabetes-related stress, communication with providers. And to try to understand maybe what was happening during the clinic visit, we did a structured record review of each patient's progress note at that initial PCP visit to look for any documentation of diabetes management discussion or diabetes deprescribing. In addition to looking at deprescribing and patient and self-report and documentation differences, we also looked at, were there any potential harms to deprescribing? So the safety outcomes were, was there any difference in hyperglycemia diagnosis related emergency department or hospitalizations? You might imagine if you cut back on medicines, you might get the opposite effect and get hyperglycemia. We also looked at the proportion of patients in the two study arms who had A1Cs above 8, because one of the concerns about deprescribing is what if their diabetes gets out of control? So we looked at that at 6 and 12 months. And then this is a little bit of a niche outcome, but we wondered if patients were deprescribed in the first 6 months, how many of them were undeprescribed or essentially maybe decided to go back on their original medicines in the subsequent 6-month period. Okay, so that's our study design. Let me describe a little bit about academic detailing, and then I'll describe the handout we gave the patients, and then we can look at the study itself. So what is academic detailing? Well, I don't know if others share a similar experience, but when I was a resident back in the old days in internal medicine, the hospital was crawling with drug reps. And so they were so nice. They like gave us our lunches during res report, and they gave us really nice pens. And they were doing their job, which is to encourage us to buy their products, which are generally new and expensive medicines. And so academic detailing kind of grew out as a counterbalance to this. And thankfully nowadays, I don't think they have drug reps in hospitals anymore. But what academic detailing is essentially discussing the evidence behind medications, behind treatment choices. And it's often done in the context of case presentations. So it's a way of teaching clinicians to do the right thing based on the evidence. So for our study, we conducted academic detailing for all physicians enrolled in the study. And we created a 30-minute presentation. It was conducted virtually because we started this project during COVID, and we just kept with it because it worked well. And one of the key things about being a pragmatic clinical trial is that we didn't try to make physicians make time for our academic detailing. All primary care practices generally have a weekly or biweekly meeting, like a working meeting where they talk about, I don't know, flu vaccines and talking to the MAs, just kind of like a business meeting. And so we got on the schedule for all of our involved primary care practices, and we did this 30-minute academic detailing presentation. The presentation was led by Dr. Lisa Gilliam. You can see her picture there right in the middle. She's one of our co-investigators. And she is a diabetes endocrinologist. And she's also, at the time, was the diabetes quality lead for all of Kaiser Permanente Northern California. So a well-known and very well-respected expert in diabetes management. Our academic detailing, I'm going to show you a handful of slides to give you the gist of what we did. And basically, she introduced the idea that hypoglycemia worsens with aging, and there's a lot of reasons for it. It's hard to administer insulin when you're 93 years old. The symptoms become less noticeable, and obviously the consequences are more severe. And then she described what deprescribing was, and a really nice visual about, as you get older, the risk-benefit ratio of tight glycemic control starts to flip, and the drawbacks begin to outweigh the benefits. And again, ideally for working clinicians, one of the best ways to teach is through cases. So our academic detailing had case presentations, also gave clinicians the opportunity to ask questions about their own patients, how to approach deprescribing in their practice. And then we also showed them that because this is a randomized clinical trial, half of the physician's patients would also be getting a handout that I'll talk about. So the way that our study was designed is that all participating physicians received academic detailing. Physicians were randomized, and then the eligible patients randomized to the academic detailing plus handout, those patients got a handout. And then the patients of the physicians randomized to academic detailing alone got a basic handout about wellness. This was the handout that the patients received. The way we delivered it was when patients consented to participate and understood the study, the week before they had a scheduled appointment with their primary care physician, we sent them a PDF of this, or we mailed a hard copy, depending on their preference. And then a day or two before their visit, we actually called them and made sure that they opened the PDF, got the email, and looked at the handout. So this handout, it's one page front and back. And the front page is essentially a patient version of academic detailing. Talking to your doctor about diabetes. Are my current medicines still right for me? That, for many patients, that's kind of a new concept. It's also in the context of getting ready for your visit. And it introduces the idea that you might need to reduce or stop medicines that you no longer need. And then as you get older, you're more sensitive to the effects of insulin or other diabetes medicines. And there's this idea that the benefit should outweigh the risks, but then, the risk is hypoglycemia. So it also sort of says that it's okay to reduce medications. That's actually part of what current guidelines recommend. But ultimately, it's a shared decision between you and your doctor. On the flip side, the back side of this handout, we have 5 questions to sort of get patients to think about their values and preferences. How satisfied are you with your current medicines? How important is it to have good blood glucose control? On the other hand, how important is it to avoid major side effects? Do you want to stop or reduce medicines that aren't helping? And how comfortable are you with this idea? And then at the bottom is sort of really the prompt. Check one of these boxes. Ideally, I'd like to discuss stopping or reducing medicines with my doctor, or I'd like to discuss it with my family or caregivers first, and maybe that leads to discussing with their doctor, or maybe they don't want to make changes or they're not sure yet. So this intervention was conducted between, oops, I went the wrong way, between September 2020 and March 2024. And it was published in JAMA Internal Medicine last month. So this is hot off the presses for your enjoyment. Our primary analysis was the comparative effectiveness RCT. And as I said, we're comparing academic detailing alone versus academic detailing plus a pre-visit patient handout. We enrolled 211 primary care physicians across 6 practice regions of Kaiser Permanente, Northern California: Napa, Vallejo, South San Francisco, San Bruno, San Leandro, and Union City. So for those of you who are familiar with the Bay Area, it's a fairly diverse group of practices with diverse demography and urban, suburban, and quasi-rural. So a good representation of the kinds of patients that we take care of. Here's our consort diagram for the study to give you a sense for what it was like to try to implement an RCT in this area. Those practices that I showed you on the prior slide included 268 primary care physicians caring for 3,300 some patients. 57 of those 268 were not able to attend the scheduled meeting where we did our academic detailing. And so the patients of those PCPs were excluded. Part of our IRB process is that we send an email to each physician with the list of their potential patients, and they're allowed to exclude patients that they don't want us to contact. So that was 92 others. Other patients didn't meet the inclusion criteria for various reasons. So we had about 1,900 patients to begin our enrollment process, and we had a goal of enrolling 440 total. 817 were not interested in participating in our study. And then the rest, either we didn't get to or we couldn't get to, and were not part of our study. So ultimately, for the comparative effectiveness RCT, we randomized 211 physicians into the 2 arms, and with that was 450 of their consented patients. Our consent rate for patients was 36%, which I think is pretty good for a much older population. And then as you can see, we had one arm, 109 physicians and 232 patients, and the other arm, 102 physicians and 218 patients. A little bit more about the data around implementing the clinical trial, and then we'll talk about the results. So of the potentially eligible physicians in the practices that we work with, the differences between those who attended and were unable to attend were pretty small. They were basically the same age, same number, in their mid-40s, and had been in practice 16 to 17 years and had fairly large patient panel sizes. There was a small difference in the percentage of female physicians who attended versus not. So a little bit of a increased representation of female physicians in the participating group. These 2 tables show success of randomization. They show physician characteristics and then their patients' characteristics. So as you can see on the left, physicians in the 2 arms were very similar to each other. If, like I said, 45 years old, about 2/3 women, 17 to 18 years in practice, large panel sizes. For each physician, there are an average of 2.1 patients of theirs enrolled in retro. The patients in this study were elderly, average age of about 80. About half were women. A significant proportion had a high school education or less. somewhere around 25%. A quarter of patients had high school education or less. Their baseline A1C was 7.5%, which is considered, quite good control for this age group. And as you might imagine, 80-year-old patients with diabetes were on quite a, significant number of prescribed medicines, somewhere between 7 and 8 medicines prescribed. Another feature about the conduct and strength of our study is that despite the age and comorbidity of our population, we had very little loss to follow-up that did not differ between study arms. We only lost 2.2% of our patients at the 6-month primary outcome stage, and over 12 months, we lost to follow-up 6.2% of our enrolled patients. Okay, so that's our study. That's what our academic detailing was. That's what the handout to patients was and how we delivered it, and a look at sort of our implementation of the study. Now we can talk about our results of the comparative effectiveness RCT. So this is kind of the money slide here. And this is why I got published in JAMA Journal of Medicine, but we demonstrated significant difference in deprescribing rates at 6 months between patients in the arm where a pre-visit handout was given to them compared to patients in the arm where they had sort of a basic wellness handout. 15.8% of patients in the academic detailing plus pre-visit handout had deprescribing at 6 months, compared to only 9% in the academic detailing alone arm. This was an adjusted difference of 77.5% and was statistically significant. So all these physicians had academic detailing, and if their patients had just a piece of paper before their visit, almost twice as likely to have medication deprescription. We're also very interested, obviously we're not deprescribing for the sake of deprescribing, we're trying to avoid hypoglycemia related adverse clinical outcomes. And this is, the study was powered to look at deprescribing, and so it's not a huge N, and not really powered to look for clinical outcomes, but we did show that in the first 6 months for each patient, there were no emergency department related hypoglycemia admissions in our academic detailing plus pre-visit handout arm compared to 4 events in the other arm, and that was statistically significant. We also were wondering what was the extent to which the differences we saw at 6 months were sustained at 12 months. It's important to keep in mind that this is essentially a one-shot intervention where most of the physicians had one exposure to our academic detailing, and the handout was given to patients at that next visit after the academic detailing sessions. And yet even 12 months later, with no further support or intervention, the difference between the 2 arms in deprescribing remained. It actually grew a tiny bit. The difference was a 7.9 risk difference %. This was just outside statistical significance, but obviously the differences are in the right direction. And then ultimately over time, the difference that we saw in hypoglycemia related admissions was also no longer significant, but again, in the right direction. So those are the results of our primary outcomes at 6 months and also some of our secondary outcomes. In other secondary analysis, we found no difference in self-reported severe hypoglycemia events, although they were rare, and they were again in the right direction. The problem areas in diabetes instrument, there were no difference in scores. And then we also administered the perceived efficacy in patient-physician interactions. So, could we measure a change in the quality of the interaction? And we're not able to show differences in those scores. One thing that we did do was, as I mentioned at the beginning, we did a structured chart abstraction of all the visit notes, all the primary visit notes for each patient with or without the handout. And there was significantly more documentation of diabetes discussion in the arm that had the handout. Almost 60% of visits with the physicians of patients who had the handout had some sort of documentation in the progress note, compared to 48%. that was statistically significant. You might ask, like, does that matter? And obviously the answer is yes. Um, the there's two issues in my mind, is that in primary care, when a patient with diabetes goes to see their doctor, especially an 80-year-old patient, diabetes is often the fourth or fifth or sixth thing on the list. Generally, you deal with like acute symptoms and various things. And so one of the problems in diabetes management, the clinical inertia that happens on either end of the spectrum, has to do with not getting around to addressing diabetes at a primary care visit. And so I was actually very gratified to see that there was more diabetes discussion documented. And that's obviously a surrogate marker, but physicians don't bother documenting stuff that, is not important. So I think that, this is surrogate evidence that I think we actually made a difference of what was happening in the visit for many patients. As I mentioned, we also tried to explore any evidence of harm, and we were unable to show any negative consequences of deprescribing. For example, hyperglycemia-related emergency departments and hospital admissions were actually quite rare, less than 1% at each arm, and there was no difference between arms. Glycemic control, about a quarter of patients had A1Cs above 8% at 6 and 12 months, but there was no statistically significant difference between arms in glycemic control or loss of glycemic control. And finally, this sort of niche outcome. There were 49 patients deprescribed at 6 months, and from months 7 to 12, only 7 of those 49, or 14%, were no longer deprescribed or undeprescribed or reverse course, like maybe there was a mistake there. And there was no difference between study arms in that reversal. So those are the main findings, the primary, secondary, exploratory findings of our RCT. And as you recall, all the physicians in our comparative effectiveness RCT received the academic detailing. And then, we tested in the RCT the marginal benefit of engaging the patient, not just the physician, in this complicated process. But I also really wanted to understand how was this different from what was already happening in usual care? To what extent were physicians deprescribing in this patient population without academic detailing? So to answer that question, we developed a usual care temporal cohort. And so we actually developed 2 cohorts of similar physicians and similar patients in the first year of the study. And our question was, how did the retro deprescribing rates differ compared to usual care colleagues over 1 year? The way we set up this parallel cohort analysis was that we took all eligible patients of all the PCPs who attended academic detailing sessions. So there were 211 PCPs, and as I mentioned in the RCT, 450 of those patients consented to participate. But we didn't want to bias the analysis by participating consenting patients. So we took all of the baseline eligible patients, whether or not these patients participated in the study itself. And then we had 2 comparison groups. One was we looked at the 35 PCPs who were unable to attend the retro sessions in the retro clinics. This has the advantage of controlling for any clinic type differences, since it's the identical clinic, the same MAs, the same structure. But there's a potential bias in there might be confounding as to why physicians were unable to attend the academic detailing sessions. To counter that, we created a second cohort, which were all the PCPs and retro eligible study patients in Kaiser Permanente, Northern California primary care practices geographically adjacent to the study, to the practices that were part of retro. And I'll also say that there was no selection bias. Essentially, every practice we approached, physicians agreed to be part of this study. So we're not comparing eager practices to reluctant practices. We basically chose practices that were convenient, where maybe I knew the guy who was running things. And so there's no bias in the selection of practices. And then, so geographically, what this looks like is we're looking at, in cohort number 1, 35 PCPs from the same 6 practices that were part of retro who didn't attend academic detailing. And then you'll see in the green boxes, a separate cohort was 260 PCPs from neighboring practices. So the green boxes next to the red boxes. Okay, so I'm going to change I'll show you the results of this study. I'm changing the box color from blue to green just to highlight the fact that this is the cohort analysis, not the RCT analysis. And so what this shows is the characteristics of the physicians in the 3 comparisons, those who attended the academic detailing sessions, those in the same practices unable to attend, and then those in the neighboring practices. And you can see the ages are similar, the years in practice are similar, the panel sizes are similar. We do have this discrepancy where female physicians were more likely to attend academic detailing sessions, but otherwise fairly similar. And here are the results of this cohort analysis. So on average, if you take all of the patients of the docs who attended the academic detailing sessions, regardless of whether or not they were the patients themselves were in the study, the 1-year deprescribing rate was 19.1%. Compared to the cohort of 35 doctors at the same practices, their deprescribing rate over the next year was 12%. And this difference was statistically significant and a relatively large effect estimate in controlling for baseline differences in physicians. And then that same 19.1% rate was compared to the neighboring practices with more physicians. And the sort of annual deprescribing rate at Kaiser for these types of patients, 75 or older, type 2 diabetes, on insulin or sulfonylureas at A1Cs below 8, was 15%. So, and that difference between academic detailing and usual care was also statistically significant. So what we can conclude from these 2 studies are, in the context of the RCT, teaching docs about the ideas around deprescribing for diabetes in older patients, and then engaging the patient in that process by preparing them for a visit with a fairly straightforward handout, was causally increased deprescribing rates. What we also learned is that when you compare academic detailing in general to usual care in a non-randomized way, academic detailing is associated with higher deprescribing rates than usual care. I think the other sort of conclusion that jumps out is that most patients were not deprescribed. Depending on which cohort you want to look at, these older patients, average age of 80, A1C average of 7.5, on insulin or sulfonylureas, 3/4 of them were not deprescribed. Is that bad? I don't know. Presumably this is all like very carefully thought through by the primary care doctor and the patient. And so it does say that deprescribing depends on the patient and the doctor. It's not something that is one size fit all. So the other conclusions, other than the actual results of our 2 study designs, are that deprescribing does not lend itself to one size fits all guidelines. It's very contextual. You could have 2 82-year-old men with A1Cs of 7.4 on the same dose of insulin, or maybe the same dose of sulfonylurea, and they could be very different people, both because one could be much healthier than the other, one could be much more adamantly connected to the idea of tight glucose control, which they've been taught to do for the past 30 years. One could be much more burdened by all the different medicines they have to take. One might not understand really what the risks are compared to the benefits. So there's really a lot that goes into deprescribing. And the fact that our deprescribing rates were, 15 to 25%, shows that there's definitely areas for improving the way that we're delivering care, but it's not the kind of thing you could just make a rule and have people follow. And so really what's coming out of this is that the shared decision making for diabetes deprescribing has to account for a lot of factors other than the simple ones of let's say, age and dose and A1C level. It depends on what they've been through. There's some patients who reported that they feel like their doctor's trying to abandon them because they don't want to do tight control anymore. And on the other side of the corner, you have patients like, thank God, like I don't need this right now. So there's a treatment history, there's the frailty level, there's the trust and risk perception. And as I showed early on in this talk, some of the facilitators for patients is trusting their doctor and understanding why this is being done. And some of the barriers for doctors are concerned that this is going to create conflict with their patients. So something like academic detailing to really make these physicians experts in this idea, and then coupling that with empowering and activating patients to think about, understand, and ask about deprescribing seems to be the best strategy for effectively deprescribing those who need to be deprescribed with type 2 diabetes. Okay, that was years of work, but only 36 minutes of presentation. Thank you very much. And I'm open for questions.
Thank you, Dr. Grant. Really appreciate your excellent presentation on the Retro-DM trial. At this time, we want to invite our attendees to submit their questions in the Q&A button. And to get us started, Dr. Grant, what was maybe most surprising or surprised you about your results from the study?
That's a great question, Jonathan. I think, like whenever you write a grant, you have to do power calculations. And when something hasn't been done before, you kind of have to make up something. And so I didn't know what the deprescribing rate should have been. Like, should have been 80%, should have been 10%. And so it turned out to be the deprescribing rate around 20%. And I guess that was kind of a surprise in that this seemed like a pretty older and frailer and complicated group. But it was, I think that's one of the things in addition to the actual RCT and cohort analysis, I think that was one of the other take-home messages is like, what is the actual, if you teach doctors and prepare patients, what's the actual size of the potential benefit?
Mike, do you have a question?
I do, thank you. I have many questions. I'll maybe start with two. And thank you, Richard. That was really a terrific presentation and a super interesting and important study. So here are my two questions, or things I would love to get your perspective on. The first, it gets back to something you said earlier about how this is like a one-time intervention, one-time academic detailing, one-time mailing to the patient. And you contrast it with the fact that deprescribing is often a dynamic, longitudinal process where people need to think about, you have a discussion, you follow up with another discussion. And I'm curious if you learned anything through this trial about opportunities or pitfalls for incorporating that longitudinal element in a way that is not overly complex or burdensome and maintains the benefits of the simplicity of a one-time mailing, but the sustainability of carrying those conversations forward.
Yeah.
Start there and then get back to my other question.
No, that's a great question, Mike. And I'm going to reframe it as kind of an implementation question, right? Like we did what we did because that's what we could do in the context of a grant or a contract. But you're offering me the opportunity to think about how this would be implemented in a sustainable, longitudinal way. And I think two things come to mind is that, I mean, academic detailing should be a programmed part of care. Like academic detailing should happen every month, every 2 months. It should be part of how we take care of our physicians. And so, we could do academic detailing on a lot of things, and physicians don't want to hear the same thing over and over again. But academic detailing about geriatric care, I mean, we don't have very many geriatricians in our system, and so it's really primary care doctors who do geriatric care. And so deprescribing is a really important element of that. And there's things that are unique to diabetes deprescribing. There's things that are unique to, I don't know, SSRI deprescribing. So that could be like a permanent series. And the thing about physician education is that cases are just really interesting. So I'll go to the same talk twice if it's different cases. So I think part of my answer to your question is it should be in the academic detailing aspect of areas where we need to get better should be institutionalized. The patient handout thing is interesting, and I think the way that we delivered it worked for an RCT in that our RA, we knew when the visit was, we sent the thing. So I'm a primary care physician, as you know, Mike, and one of the things that bugs me is when different specialists all want their thing, like they want the MA to screen for this and screen for that, and we want to send a handout for this and a handout for that, and I don't want to be guilty of that same thing. So I think that that type of educational material has to be part and parcel of a bigger picture, and it probably has to be part of a kind of a population management picture. So if you have a diabetes registry, maybe every January there's like a handout about, you need to get vaccines of a certain kind, you need to think about deprescribing. So maybe it's not, I think it's harder to link it to visits, but maybe you can link it in a more of a population distribution way.
Super
You,
interesting.
you give me some ideas for writing a dissemination grant, Mike. Thanks.
Sure. So I'll take the liberty of asking my second question and then definitely get back to the other Q&A. Were you able to get any insight from how patients completed the forms, like what they said, if they were interested in deprescribing, if they had questions, concerns, and what actually went on in the room during those visits?
Short answer is no. Longer answer is we made the decision not to collect those handouts and what they filled out. We saw it as like, this is actually an artifact that belongs to the patient. So I don't know how they answered the things on the back. And I will say that when I wrote the proposal, that exploratory aim was actually going to be audio taping visits. And then we're going to do this whole like audio analysis of the conversation. And there's this framework of one of our co-investigators developed about question asking. Who's initiating the question? Who's answering it? And it was going to be amazing. But the COVID thing happened, and so care went virtual. And there was no way for us to record virtual visits. We just couldn't, it just wasn't feasible. And so we collected like 12 visits. And so that part didn't work out. And that's when we basically shifted gears and said, well, let's at least, we can get our hands on all the visit notes. And, as you know, right, visit notes are not really great literature. So not a lot of insight, basically, to answer your question, although definitely evidence that stuff must have been talked about because they bothered documenting it.
Perfect. Thank you.
Our next audience question is, what do you think would be a good follow-up study to the retro DM trial?
Can you check, is that a program officer asking? There's so many directions to go in with this. So one direction is this idea of getting older patients ready for visits. And in that context, diabetes deprescribing and deprescribing is just one component. And so I would say one whole area of research would be, can we build something, maybe like a website with like little vignettes and little things that says, this is, you're 83 years old. This is how to optimize being a patient. Like you need to know who your care team is. Like, yeah, your primary care doctor, your renal doctor, like who actually is your team? You need to know who's helping me. Is there a social worker? Do I have a caregiver? Like, how do they interact? You need to be able to talk to your doctor, like ask questions. A lot of our older patients are, not all of them, but certainly some of them are reluctant to cross authority, let's say. And so that's a skill. So there's a lot of skill building for being an effective older patient. And the retro study is one little sliver of that. So that might be one direction. A whole nother R01, since we're brainstorming R01s, Jonathan, is deprescribing diabetes is great, but let's deprescribe everything. Like what else? How would we do general deprescribing with retro as maybe as a model, right? Clearly we need to figure out a way to get patients to think about this idea and then maybe talk to their doctors about it. We need to figure out a way generally to have doctors interested in reducing medication complexity. And what does that involve? And is there a study that includes a clinical pharmacist as part of that? A third study, since we're on the list, is it's sort of what Mike was getting at. Like, it's all well and good that I did this study, but like, how do we actually change health systems and keep that change? So what is the dissemination proposal? So yeah, anybody out there wants to write an R1 with me, I gave you 3 ideas. So, send me an email.
Yeah. Again, just want to invite our attendees to submit their questions in the Q&A. One question I had I saw was really interesting is, as you talked about the safety results, that's always important in trial design. And, any thoughts or tips for those who are thinking through, how to design measures for safety in a new trial or different design?
Okay, you caught me. So I need to confess, I didn't say this, but now I need to confess. That was actually requested by the JAMA Internal Medicine editors. So I didn't have these. I was like, whatever. But they're like, we want to show that you haven't done anything wrong. And so then we came up with a suite of, well, what's the opposite of hypo is hyper, and, control, and then this idea of backtracking. So, making a change and decided maybe that was mistaken, unchanging it. So I need to give due respect to the JAMA Internal Medicine editors who suggested that we do that. I'm glad we did because it made for a nice slide, but now I need to expose myself as a fraud. So thanks, Jonathan.
We have another attendee question. They're really curious as to whether you think pharmacists could have these deep prescribing conversations. Pharmacists have been employed for diabetes management studies, so why not deep prescribe?
Okay, that is an excellent question. And I have an answer, which is yes. And so we did another, Dr. Gilliam and I have another study that is completed but not yet published. And in that study, we developed a algorithm for how to think about deprescribing for a pharmacist. And then we randomized 100 kind of similar patients as retro. And then the pharmacist worked on the 100 in the intervention arm, and the 100 in the control arm had usual care. And she was successful. So we'll get this published, but having a pharmacist with a clear pathway, not like a strict algorithm, if this, do that, but like, if this, think about this direction, if that, had an effect. And in fact, it's an example of diabetes care that's not sort of visit based, right? She had a population to work with. She called them. She secure message communicated with the primary care physician, and it was also successful. So whoever asked that question, like, that was exactly, it's an incredibly valuable possibility. Maybe I'll come back and present that study in a year once it's published.
Yes.
We'd be glad to have you. I found this work really fascinating, and I'm a big admirer of it. I found myself wondering, partially having gotten to collaborate with Liz Bayless and the folks at KP Colorado so much, how we think about like the pieces or the tools that are in place at KP. And like, I guess I'm sort of asking about like that special sauce of like when we're trying to disseminate to other systems, because and what you think the pieces are that were really key to be able to be implementing this. It seems like really very reliably, and even though it was very pragmatic, right? Like that it was clear that it was actually really happening, and would love to hear you reflect on that a little bit.
Yeah, well, I mean, there's different levels of special sauce. I think, having complete data and tracking it in registries, I mean, that's part of how KP has been successful in so many ways of preventive and sort of evidence-based guidelines, is that we know all of our patients with diabetes, we know what their A1C is, we know if they've had their retinal exam or not. And then what happened, then the next question is, what do you do with this information? And, I'm a primary care doctor, as I've said like a bunch of times, but a lot of the care, when I used to see patients back in the old days, I would do all this stuff. And now a lot of that is being done by a population management team, often a nurse or a pharmacist who's responsible. So it's this interesting idea of where if things have to happen, sometimes we take it to a population level rather than having it on a one-on-one level. And it clearly has effect, right? And so if you think about how do you make large scale changes for populations of patients, often it's going to be through like a population level perspective. And so this other study that we haven't published
Yeah.
yet was really like, let's take all these patients and then have someone work on them, which is, it was in collaboration with each patient's PCP. It wasn't like divorced from that. But there's this idea that, this getting everything done at a visit is kind of an outmoded concept. Visits are still really important. Like you need to build trust. You need to find out stuff. Not everybody wants to be, doing emails and whatnot. But, modern medicine is really this evolution of leveraging complete data to have a personal view and then a population level view and then doing something about it. It's not enough to know. You need to have levers to do stuff.
And we would definitely like to hear the results of that next. Very, very exciting. Thank you.
I don't think we have any more questions. So I'd like to say thank you to all our attendees for joining today. The recording of today's webinar will be posted on the USDen website in the next day or so. Our next webinar will be in the late fall, and please look out for an announcement for that in our upcoming newsletters. Please complete the after webinar survey. We really like your feedback. That will come after the closure of this webinar. So thank you all and hope you have a great rest of your day.